Okay, so we're talking today about peripheral arterial disease. My name is Victoria Krejci Kitchell. I have a master's degree in the science of nursing and some postgraduate work in nursing and healthcare education. I am a registered nurse. I'm also certified in emergency nursing, and I'm certified as a flight nurse. On an aside, I am also in the process of obtaining my doctorate of nursing practice and my adult gerontology acute care nurse practitioner. Today, we're going to talk about peripheral arterial disease, like I said, and we're going to start with the introduction. So we're talking about really coronary artery disease that is out in the periphery. So it's the same process, the same problem as coronary artery disease. It's just that it's in the arteries elsewhere in the body. You may find that your patient has actually issues with their mesentery, with their kidneys, throughout the entire body. But today we're talking about out in the periphery. So we're talking about atherosclerosis. And then that means that we have this buildup of plaque in the intima here, and we'll talk in more detail about that. This can become a problem when it narrows, when we have atherothrombosis, where we have a blood clot that fills that spot. And this can also be an acute problem or a chronic problem, and we'll talk about that here in just a second. All right, so the details of anatomy and the pathophysiology. It's a subintimal accumulation of this plaque. And so when you think about the layers of the arteries, the endothelial layer that is on the inside of the vessel is the intima. And so this plaque builds up just below the intima in the layers of the arteries. The intima is pretty thin, so it doesn't take much for this to actually rupture. Now, we talked about narrowing. This, as it builds up more and more plaque, this just becomes narrower and narrower, which leads to some of our signs and symptoms, which we'll talk about. It can thrombose. So as you have blood flowing through here, you get, one little red blood cell and some platelets just smacked up against the side and they get stuck, and that gets bigger and bigger and it becomes thrombosed. In some ways, that's easier to open if that is the problem. That would be an acute issue. And because we can give clot busters like TPA or TNKs to open that up. The other big concern, though, that we have is a rupture, is where the intima actually lets go. This plaque ruptures out and plugs this hole, and there is no further blood supply distally to that. Contributing factors, endothelial dysfunction. So we can have damage to the vessel, the lining of the vessel, which encourages all of this to grow, or something along those lines. Enhanced platelet activity and dyslipidemia. So if we have problems in here with lots of lipids and platelet issues, we're going to accumulate more and more of this plaque. Inflammatory and immunological factors, and definitely tobacco. Tobacco use is going to be a really big issue for patients like this, because tobacco and the nicotine in tobacco causes blood vessels to constrict. Well, you can see if we have this small space here to begin with, and then we constrict, there is no more space to work with. And so the narrowing simply becomes so narrow that there's no blood cells passing through that space, and we have an anoxic injury happening distally to that. The symptoms are definitely going to depend on the location and the severity. The more severe, the more pain, so on and so forth. All right, risk factors. Women are more likely to have problems than men with peripheral artery disease. The older the age, hypertension, tobacco use, like we talked about, diabetes, and hypercholesterolemia. So the more cholesterol we eat, the more plaque we pack away, the more trouble that we're likely to have. Clinical manifestations. So I think it's interesting that there are 3 times as many people who have asymptomatic peripheral artery disease compared to those who have symptoms. When we talk about symptoms, their most common is claudication, and I'm sure you recall intermittent claudication. But where we have intermittent problems, when you have high activity, you can have a narrowing of those vessels, which causes pain. A clinical manifestation of pain, specifically at rest, which I think is interesting, or immediately following activity. So work those muscles really hard, and you cannot get the supply of oxygen to them in a timely fashion because of all of the narrowing and the plaque buildup. And so you have pain. Ulcerations, where tissue is not getting the blood supply and it's dying, and you have little ulcerations, and all the way to the point of gangrene. And like we talked about in the previous video, you would expect your infection to be gangrenous because we're talking about anaerobic infection. There's no blood supply to the tissue. And so this is infection that does not require oxygen. And gangrene is the disease, the infection that sets in and causes severe, severe damage. The diagnostic process. So when you have someone who's asymptomatic, you're noticing that there is something wrong. So in a just a general physical assessment, we notice that there are absent or abnormal pedal pulses, specifically in individuals over the age of 50. Especially over the age of 70, but when they're talking about 50 to 69 years old, they're looking at a history of smoking and or diabetes. So our patients who are 50, who smoke and are diabetic, have really high risk for issues with peripheral arterial disease. The next thing they want to do is to measure the ankle brachial index. And in just a few moments, a couple slides, I actually have a video of exactly how to do that. When you look at poor ankle brachial indexes, you can see that it's diagnostic for peripheral arterial disease. If it's pretty normal, no further testing is indicated. And so whatever you notice with that abnormal pulse is not related to peripheral arterial disease. And then I think it's interesting that if your pressures are actually, if that index, I'm sorry, is actually high, then you want to look at the exact waveforms and toe pressures, and may also be diagnostic. All right. When you're symptomatic, one of the things they look at is the symptoms themselves and make it pretty easy. If you have tissue loss, non-healing ulcers, gangrene, pain after exercise, but now at rest, that's pretty diagnostic all by itself. And this patient needs to see a vascular specialist. They're going to go ahead and do a CAT scan angiography or an MRA, which is basically magnetic resonance imaging with the dye to look specifically at the arteries, or other angiography. If you're symptomatic and you have just claudication and we don't know exactly what's what, we're going to go back to that ankle brachial index and look at that. And if that shows to be a significant problem, we're still going to send them to a vascular specialist and consider further testing. Okay. Here is the video about how to do an ankle-brachial index.
Hello, I'm Anne-Marie McLaren. I'm a foot specialist on a wound team in Toronto, Ontario. I'd like to demonstrate how to perform an ankle brachial index using the ankle pressure divided by the brachial pressure. To perform an ankle brachial index, you will need a handheld Doppler, ultrasound gel, and a manual blood pressure cuff. So the next thing is that you actually want to make sure that your patient is lying comfortably and relaxed for about 10 minutes to stabilize their blood pressure. It's also important to remind your patient not to speak while you're doing the test. You apply the blood pressure cuff to the patient's arm, taking care that you leave enough space so that you can still access your brachial artery. There's the brachial artery here. And then using your handheld Doppler, we're going to listen for the brachial pulse and its signal. Continue here, the brachial artery signal. Now what we want to do is we want to inflate blood pressure cuff to eliminate the signal. And then we want to gently deflate the blood pressure cuff until we can hear the signal. And we notice the signal around 100. The return of the signal is the brachial measure, or the denominator for the ankle brachial index. We would complete the process on the other arm, and we would compare the left and right. We would choose the highest measure to be the denominator for our ankle brachial index calculation. Now we're going to use and measure our ankle index by locating the pulses in the lower limb. In particular, we're going to be looking for the dorsalis pedis pulse, which is located on the dorsum of the foot, and the posterior tibial pulse, which is located just behind the medial malleolus. So I've located the dorsalis pedis pulse on the dorsum of the foot, and I can also feel the posterior tibial pulse, which is located just behind the medial malleolus. And I'm going to repeat the procedure by applying the blood pressure cuff. And we're going to again look for the pulse signals using the handheld Doppler to acquire our ankle pressure measurements. So first off, I'm going to apply the blood pressure cuff to the ankle. Now we're going to apply some ultrasonic gel to the dorsalis pedis pulse. Then we're going to use our handheld Doppler to locate the dorsalis pedis signal. A nice strong signal here. Now we're going to repeat like what we did in the arm with the foot. We're going to inflate the blood pressure cuff until we no longer hear a signal. We're going to gradually decrease the pressure until we hear a return signal. We can see it returned at 100. Now that we've located the posterior tibial artery, we're going to apply a small amount of ultrasound gel. Using a handheld Doppler, we're going to locate the posterior tibial pulse and its signal. Now that we have located the posterior tibial signal, we're going to inflate our blood pressure cuff until we no longer can hear the signal. And then we're going to gradually release the blood pressure cuff until the signal returns. And again, we saw that at 100. Now we're going to repeat this on the other ankle. We're going to again measure the dorsalis pedis and the posterior tibial measure. We're going to take the highest measure and use that as our numerator for our calculation of the ankle brachial index.
Okay.
Hello, I'm Anne-Marie
Oops.
McLaren.
That's not what I meant to do. There we go. So management. So what do we do about our patient when we have discovered that they are either at high risk for peripheral artery disease or they've been diagnosed with peripheral artery disease? And most often we're going to find that they've already been diagnosed, and now our job is to look at how do we prevent this from becoming any worse. So we're going to look at medical management first, of course. Risk factor reduction. Well, I can't do much about how old I am or the fact that I'm a woman, but I can definitely talk about lifestyle changes, stopping smoking, controlling high blood pressure that I have. Obesity, we can certainly manage obesity by looking at diet, exercise, weight loss, things like that. The other thing is antithrombotic therapy. We can prevent blood clots by taking aspirin. A lot of patients are going to start with just aspirin, but then they may also get into an antiplatelet therapy. They may get into clopidogrel if they are unable to take aspirin. Statin therapy to really work on all of this cholesterol. Let's see if we can get some of that plaque to reduce in size and pull that back out. I'm not sure how effective that is at reducing plaque, but it certainly will reduce the continued accumulation of plaque. Glycemic control is going to be really important. We know that the higher the blood sugars, the more easily the intima is damaged. And the more easily that is damaged, the more inflamed it can become. And then we have a buildup of even more plaque. When you look at patients who have high blood pressure and high blood sugars, they have even more issues with peripheral arterial disease. Then we get into surgical management. Now we're talking about revascularization. And that can range from balloon angioplasty to a stent placement, all the way to bypass. And so there's so many options with percutaneous surgical management that is very often where they like to start. But then we can lead to bypass if we have, especially if we have a complete and total occlusion. Ultimately, these patients can end up with having that limb completely removed, and amputation is the only choice because they simply cannot open that vasculature back up successfully. All right, I really hope that this was a helpful presentation. The vast majority of my information came from UpToDate. The reference is here, and I hope you have a fantastic day.